Hi, everybody. I'm starting to see loads of people joining us here this evening, and I hope you're all well. I know it is nice early afternoon in certain parts of the US, and in Ireland, it's actually just gone 11 p.m. So the pajamas and the slippers are very close by. Whereas Professor Linda Yang here beside me has just finished her day's work. So we're delighted to have you all here this evening. We're just going to give it another 30 seconds or so as we see all the participants join us. So again, thank you for giving up your time this evening. And I hope that you find this webinar useful and that we will all learn something, because I find that when I speak to surgeons all around the world, I always learn something else about endometriosis and something that maybe I haven't considered. And I think this is a fantastic opportunity for that. So for those of you who don't know me, my name is Kathleen King. I am an endometriosis advocate for the last 25 years. I've lived with endometriosis and adenomyosis for 35 years. So aside from giving away my age, I've done a lot of voluntary work around education and around advocacy as well within the patient community. And I host a podcast called JARG. But tonight we're here with the telehealth crew, and I'm delighted to say that we have Professor Linda Yang with us. And Linda, I'm not even going to attempt to give your bio because it is absolutely fantastic. And you know, it's a real honor to be able to chat to you this evening. So I'm going to hand over to you to give us a wee bit about yourself.
Thank you so much, Kathleen. And thank you again to telehealth for allowing us to come together and really kind of talk about a topic, obviously, that has significant meaning and impact. In terms of who I am a fellowship trained minimally invasive gynecologic surgeon at Northwestern in Chicago. I have spent a lot of time caring for women and other individuals with endometriosis. And, I'm continuing to learn. So that's why, tonight is a great forum, because hopefully we can kind of learn together and talk a little bit more about important topics related to this condition.
That's fantastic. And I'm sure in your day-to-day work, do you concentrate specifically on endometriosis, or is your practice quite wide?
My focus is gynecologic surgery. So in terms of the patient population that I care for, many patients with endometriosis, but other conditions like uterine fibroids or other menstrual related disorders, pelvic pain. That's, the large part of the types of patients that I see.
And look, we're complex human beings, and certainly women and other individuals who may present with pelvic pain or signs and symptoms of endometriosis, we need quite an intensive workup, and to differentiate between maybe what could be another condition or could be endometriosis. Can you take us through maybe this sort of preoperative planning? So if we came to you as a patient, what could we expect first to happen?
For me, what I usually try to focus on during the first visit is actually just being a listener and trying to really hear what my patient has to tell me in terms of their concerns. And then I try to be a little bit more focused in terms of the specific questions. And because we're talking about endometriosis, in terms of like the specific questions that I really like to hone in on are types of pain, triggers of pain, and key kind of features that might raise a red flag and, clue me in onto whether or not they may have endometriosis if they haven't previously been diagnosed with that condition.
And in terms, we see some of the international guidelines where now clinicians are able to make a presumptive diagnosis based on really good imaging, or maybe based on the presentation of symptoms and the history that the patient comes in with. And do you find that you're starting to see a shift now that maybe patients are coming to you with, that sort of information in hand, or are you having to start at the very beginning with patients?
I think it's definitely a mix. I have some patients who have never even, been considered to have endometriosis. But I will say there was a shift in reliance on other alternatives, including 3D ultrasound or more dedicated gynecologic ultrasound, although in the United States, I think we have less access to that, but also the incorporation of MRI in the evaluation and workup. So I am seeing a trend towards that being completed in advance before patients actually come to the office. And I think it's a movement in a positive way.
Yeah, it certainly is. And I think, certainly coming from, like countries within Europe where, we have a public health waiting system where, our primary care physicians are, maybe struggling to refer people in and maybe need that help with that differential diagnosis. And I'm sure it's very similar with yourselves. If you have that, filter, you can help prioritize your patients as well. And you touched a wee bit there. Sorry, go ahead.
Oh, I was going to say, I actually think that's probably our referral patterns in the United States. I think we have a lot of work on that in that arena in terms of getting patients referred in an appropriate and timely fashion. So I think that is something that really needs to be improved upon as well.
Yeah, and isn't that the thing worldwide? We are facing huge delays in diagnosis. We're talking about averages. We hear different countries, 7 to 12 years. You've seen patients, I've spoken to patients where they could have maybe waited 20 years with symptoms before they've had a diagnosis. And that sort of brings me around to the patient's symptoms. And you mentioned red flags. So if a patient sits down in front of you, and I know for most people here this evening, they probably have a diagnosis, but if they're looking at maybe a loved one or maybe like a relative friend who maybe has some symptoms, what are the red flags for you that makes endometriosis stand out?
I think most classically, we think of painful menstruation. And, truthfully, menstrual pain should not be something that limits your ability to go to work or to school. Perhaps, having mild pain where you can still function might be within the normal range, but certainly when you hear stories of certainly teenagers, who can't go to school because of the severity pain, that is not normal and should really be brought to the attention of the healthcare team. The other concerning symptoms I'll say that go outside of, period-related pain would be pain that exists even in the absence of periods. So, pain that can be present, mid-cycle or sometimes evolves to a point where it becomes everyday pain. And then certainly other features would be painful pain during defecation or having a bowel movement. That oftentimes is a hallmark of endometriosis, particularly deeper disease. And then in individuals who have penetrative intercourse, the other symptom that can also be reported is pain during penetrative sex.
Yeah. And that's one of the things that we find, that patients don't often volunteer that information because they may not necessarily know that their symptoms are abnormal, or the clinicians sometimes don't feel comfortable in asking. So there's a wee bit of work on both sides there, isn't there, to make sure that we're all aware of the symptoms and that we're able to report that back to our clinicians in a very comfortable manner as well. And I think that's a shift I've seen over the years, that, people are now becoming, more empowered to talk about their health and talk about their symptoms. And I think that's, sort of helping, but we're still seeing again that very long delay to diagnosis. So I think when a patient has come to you and they have a suspicion of endometriosis, or they feel that, their symptoms have led them to this point, or maybe they have some imaging, can you tell me then about the surgical process, why we still need a laparoscopy in this case, to diagnose and then treat at the same time?
I think that's a really important question. Although there are some cases where we have an established diagnosis without requiring surgery, surgery in some societies is still regarded as the gold standard, although again, the trend is kind of shifting. I would say that, there can be different reasons to go about and to recommend surgery to a patient. I think the first is potentially establishing or confirming a diagnosis through visualization and tissue sampling in terms of obtaining biopsies and obtaining a histologic diagnosis, which means relying on our pathologist colleagues to really examine the tissue. And then the second component, I think, of surgery is, how can surgery be effective in treating symptoms or potentially improving fertility? So those are the things that we really like to focus on in terms of why surgery is important.
Mm-hmm. And in terms of that surgical diagnosis and confirmation, should we be aiming for that very early in, I suppose, first of all patients of all ages? And is there a long-term benefit to the patient of having that diagnosis early?
Yeah, I think sometimes it comes down to individual counseling and shared decision making in terms of timing of surgery, in terms of if the patient has tried other therapies before, or they're just kind of beginning their journey in terms of endometriosis treatment. But I think that the sooner a diagnosis is made, I'll say, I think not just kind of improving quality of life related to pain, but I think there have been some studies, qualitative studies, that have shown that providing an early diagnosis can translate into a patient feeling validated, almost, feeling more liberated in terms of having a diagnosis. And then once a diagnosis is made, that can then enable, you know, um, those patients to kind of seek out additional resources and support to really help educate them and, find a support system, so to speak, not just within the healthcare system. So I think there's great value to an early diagnosis beyond just kind of treating the pain.
Absolutely. And I think, behind the screens here, I can nearly hear people cheering on that one. And just back to people who've tuned in this evening, you will have an opportunity to pop your questions into the Q&A box there. And yeah, this session is being recorded. So if you miss any of it, or you want to listen back or share with your friends and family, this will be a great opportunity, and it will be available after the event as well. So back to the sort of surgical diagnosis again, and we almost all, I think, can remember our diagnostic surgery, and we'll remember that feeling of elation and that feeling that now something can be done. But we also hear in the media, and we hear maybe from other, sources, that there's risks with surgery. We may lose our fertility. We may end up with chronic pain. So can you take me through maybe sort of, some of the benefits versus risks of maybe that sort of first surgery, and maybe, subsequent surgeries as needed?
I'd be happy to. So, in terms of an initial laparoscopic surgery, I think assuming, there aren't other, significant health related matters that would, place the patient at risk to undergo surgery. I think, although there are operative risks with a laparoscopy, in, patients who are undergoing laparoscopy with whether it's a high volume surgeon or even a generalist OBGYN, I think laparoscopy in general is overall quite safe. The risk of major complications that have been associated with laparoscopy is still regarded as being very low, less than 1% of the time. And then, going beyond just kind of the laparoscopy itself, questions about, will this have a negative impact on future fertility just by doing that initial surgery? I would say that there hasn't been any data to establish a correlation between having an initial surgery and having diminished fertility downstream. Similarly, laparoscopy, because we're able to utilize fine instrumentation and allows for more precise tissue handling, the likelihood of developing adhesions just from doing that surgery is actually very, very low.
And I suppose it's fantastic when you see, the development of laparoscopy over the years, and now we have robotic surgery as well, and the shift towards minimally invasive, because again, I sort of come from a time where people were diagnosed, with laparotomy, which was open surgery. And you had, the risks, and you had as well too the risks of infection and recovery. So it's great to see that progression. I'm actually making myself sound like I'm 100 years old now, so I'm gonna stop that thread. So in terms of benefits for the patient at that surgery, so they've got their diagnosis, they've had that really positive, confirmation that it's not all in their head, that, what is happening is real. Can we expect to have our disease removed at that surgery, or, is it a case of it may have to be rescheduled, into a second or third surgery with different specialists? What's your normal when you have patients in with you?
So in my practice as a gynecologic surgeon that is high volume, my care plan usually consists of performing the laparoscopy, doing an assessment, and then, really focusing on being as complete as possible in terms of treating the disease that's present. The different techniques that are available for treating endometriosis consist primarily of removing or excising tissue or destroying tissue via fulguration or ablation. So I rely on using excisional techniques in treating endometriosis. There are occasions where, we may not anticipate the severity of disease, I'll say, or a location of disease that potentially may put the patient at significant risk of complications, including, bleeding or an injury to a blood vessel or other important nearby structures like the intestines or the bladder. And so a lot of those scenarios I talk about upfront in the office so that the patient and I can have a more complete conversation about her wishes or their wishes in terms of, how complete we should be, or would they rather have a more conservative approach and, potentially plan for an interval or a second operation where we can be more thoughtful in our approach in terms of a bowel resection, let's say, in coordination with other surgical colleagues.
And that is the real underlying thing to modern healthcare, isn't it? It's informed consent. Having that discussion with the patient, giving them the pros and cons, the benefits, the risks, everything, and involving them in that decision. And, I'm really encouraged to see that now with a lot of clinicians, especially a lot of surgeons. They're giving the patients a lot more information. And again, the patients are coming a lot more armed with a lot more information as well, a lot more questions. So it's a good two-way sort of balance, isn't it? And you've mentioned excision surgery there. Can you tell me why that's your preference? And, for anybody who's listening in here who maybe wouldn't understand or, has concerns around the difference between ablation and excision.
So the excision technique, in terms of why I utilize this technique more, I think partly is based upon my training. So I had the privilege of completing my fellowship with Dr. Ted Lee, who's fairly well known in the endometriosis world, and so through kind of his mentorship, surgical mentorship, I think that's what really kind of built my my foundation and my philosophy, so to speak. And so, the purpose of excision is really to be able to be more complete when you're treating an endometriosis lesion, not just how kind of widespread the lesion is, but really how deep the lesion goes. And so by removing it, by cutting it out, you're intentionally trying to kind of undermine the depth of the disease and to really kind of get to the root of the disease, in contrast to destroying the area of endometriosis may be insufficient, let's say, in terms of really getting to the depth of the lesion. So those are kind of the differences I see, and that's why I favor the excision approach.
And us lab folks, we just love getting samples down. So you've got something to send for pathology as well too. So like that's another sort of benefit, isn't it? In terms of surgery and fertility preservation, is there anything that patients should be concerned about, or anything they can do ahead of their surgery? Do you recommend like any particular blood testing or anything that they would do before surgery?
Yeah, I think there are always a lot of questions about, surgery in the setting of desired fertility. I think that, I always encourage patients who have desire for future fertility to, again, kind of be proactive and utilize resources. I think that, depending on, where a patient is in their reproductive time span, I'll say, or their prior history of fertility attempts. It really does depend on that in terms of my recommendation. But I think, we partner a lot with our fertility specialists. And so, sometimes we bring up options like, fertility preservation through egg freezing, for example. Not specifically before endometriosis surgery per se, but we know that patients with endometriosis may have a higher likelihood of being affected by infertility. So those are always conversations I try to, potentially incorporate into our visits.
Mm-hmm. And I suppose, again, giving patients back that option as well, and knowing, I suppose, that there is, potentially a risk to fertility there as well. In terms of, we think of deep endometriosis, we're thinking of patients with endometrioma. Certainly there's a risk to fertility by removing an endometrioma and also by leaving the endometrioma in place. And I know it's a very individual and can be, very patient to patient specific, but is there any general guideline out there at the moment that would sort of cover those scenarios?
There are some existing guidelines, and I think those are guidelines related to whether or not individuals with an existing endometrioma should have surgery. I think the reasons to recommend surgery in patients with an endometrioma is obviously symptom driven. So if a patient has pain from the endometrioma, that would be a reason to recommend or favor surgery versus leaving it be and just watching it. But in specific scenarios where patients potentially are about to undergo, assisted reproductive treatments like IVF, the consensus, I think, is to, if they don't have any pain, is to potentially not operate on the endometrioma first, because in the process of removing an endometrioma surgically, we do find potential diminished ovarian reserve as a result of doing surgery, which would then potentially reduce the likelihood of successful egg retrieval. So those are specific kind of guidelines related to patients who are undergoing fertility treatments. But you're right, having an endometrioma is not a good thing. It can potentially diminish ovarian function. So in patients who are attempting natural pregnancy, certainly removing the ovarian cyst could be potentially beneficial in that setting.
It is. It's very individual, isn't it? And it's important, I suppose, to work very closely with the fertility clinic or, the person who's looking after the sort of fertility side of things as well. And in terms, I suppose, again, just sort of on that fertility theme as such, we know that, patients with endometriosis, can also have maybe additional things going on. And there's lots of other factors that feed into that, so certainly while looking at the endometriosis surgically is one side of the treatment, they may also need additional supports and treatments as well. So I think that's always sort of worth for patients to keep in mind, isn't it?
Mm-hmm. Absolutely. So, there are, the other kind of benefit of, doing surgery in the fertility world is, to better assess anatomy and whether or not there's distortion of the fallopian tubes or deeper disease that potentially could be missed. I think, the true benefit of removing deeper disease for fertility, though, I think some of the data is a little bit mixed there, but certainly if a patient has symptoms that are pain that could be attributable to the deeper disease, that would be a reason to go ahead and to treat the endometriosis through removing it.
Yeah, and unfortunately, for most patients, the treatment path for endometriosis is usually a choice between quality of life or fertility. And sometimes those paths don't cross really well, and it may be a choice between one or the other, certainly for a short period of time. I think when we think of symptom reduction with surgery, and could you take us through maybe how surgical excision of endometriosis can help to improve symptoms?
Yeah, so when you think about like where endometriosis typically resides, the locations are typically in the pelvic area. And then, looking at the locations, usually it's in the spaces that are close to and behind the uterus. So the spaces that we kind of call the posterior cul-de-sac, the ligaments, the uterosacral ligaments, near the ovaries or in the ovaries. Although endometriosis can unfortunately find itself in other spots too. But when we proceed with treating those areas, the outcomes that we see in terms of specific types of pain reduction are reduction in period-related pain, so dysmenorrhea. We also see improvements in patients who may have pre-existing pain during bowel movements, which is dyschezia. And then also potential improvement in patients who are having painful intercourse, so dyspareunia. So those are the 3 Ds that we always kind of like to ask about. And then those are how you can also kind of assess treatment response by kind of re-examining or asking them about those symptoms specifically post-operatively.
And surgery, like everything, is step one in the healing process, isn't it? We, like to make sure that, patients are aware that there are other additional supports after surgery, like, you've got pelvic physiotherapy, you've got maybe, a registered dietitian support as well too. There's lots of things that you need to sort of build on top of the surgery. And I think in terms of symptom relief and restoring anatomy as well, are there ever occasions where, say if you have to do a bowel resection, or you have to maybe look at removing the appendix, or maybe, removing maybe fallopian tubes and that, what does that look like when you go in there? What's your goal when you sort of go in to do something like that?
So I think we had touched upon it earlier, but really, having a shared decision-making approach in terms of, is the goal to try to do everything at once, right? To kind of prevent the need for another surgery, which unfortunately many of our patients require. So, if we, see areas of endometriosis that are, on the appendix or bowel, as long as we've had, a complete and thorough discussion prior to, although there can be a little bit heightened risk with those added procedures, the value of doing those procedures is that you have, reduced the burden of disease, or hopefully eliminated it at the time of surgery.
And again, I suppose reducing the risks of multiple surgeries is, has its benefits as well, doesn't it? And I think in terms of, the sort of hot question that a lot of us will have is, can you tell if my endometriosis is going to come back? Do we know what the recurrence rate is going to be like, or can you tell me what I'm going to feel like in 5 years' time? And I think that's probably the $1 million question for a lot of people, isn't it?
It is. And, recurrence rates have been reported, but the studies that we have really are not comprehensive enough. We'll see a variation in terms of what's been reported in terms of recurrence rate. So probably the most commonly cited kind of percentages are somewhere between, 25 to 40 to 50%. And that's after patients have had their one surgery and then following them over time. So, the follow-up, has ranged from about 2 to 5 years. We don't really have good data going up to 10, 15 years. So that is data we just don't have. And so, that is typically what I, refer to when I'm talking about recurrence rates. I think one point though is that, there are some patients in whom I've operated on who have endometriosis, and we resect it. And then 3 to 6 months later may have more pain. And that's a harder situation because, it's actually not too common for endometriosis to come back that quickly, although it can happen, especially if there's some left behind. But I think those patients that have pain that recurs very shortly after the surgery, I think it's very hard to diagnose recurrence often, especially if you don't have, imaging findings that can help you with that. And again, there's other things that could be going on too, to your point, pelvic floor and, potentially helping focus on those other causes.
Yeah, and we know endometriosis likes to keep a lot of bad company. So adenomyosis tends to come into the mix. And we hear people with painful bladder syndrome as well too. So I suppose there's lots of drivers, for us to explore as well if we do have continuing symptoms. And could you maybe just touch very briefly on the instance of adenomyosis in endometriosis patients?
Yeah, so unfortunately, they are cousins or relatives to each other. So rates of adenomyosis are quite high, and unfortunately, because often we don't have good diagnostic tools for adenomyosis in many instances, especially if there's not a focused GYN kind of sonographer who's adept at kind of looking at changes of the uterine architecture. In my practice, we typically do have our patients complete a preoperative MRI. So I think that's very helpful in our preoperative counseling, because then we can be more complete about expectations after an excision surgery if it's done in isolation without a hysterectomy in patients that also have underlying adenomyosis.
Mm-hmm. And, when we think of, adenomyosis, we certainly know that the hysterectomy is going to take that, disease out. It's going to take the uterus out. It's going to take the disease within the uterus. But just to sort of refresh people's thinking as well around a hysterectomy for endometriosis. And we see this reported sometimes in the media. We see it reported from patients who have relief after hysterectomy. And can you talk to me a little bit about the role of hysterectomy in endometriosis, if there is one, and sort of how that fits in?
Sure. Can you still hear me okay? I just had to switch out my earbuds.
Yeah, no, I can hear you okay.
Okay, great. So I think you're asking about what is the role of hysterectomy? So, certainly, we would, not advise patients to regard hysterectomy as being curative. However, in thinking about what are their primary symptoms. So if they have a significant element where the pain is related to menstrual pain, and even in the absence of having adenomyosis, there can be a benefit in that regard. But also not just doing the hysterectomy in isolation, really being sure to treat any other areas of endometriosis that may be there and are likely there, because, essentially a hysterectomy will kind of be an incomplete, solution to their symptoms. We do know that recurrence rates, in terms of endometriosis, are a little bit lower in those patients who undergo a hysterectomy, but it's still not, low enough where patients, shouldn't continue to monitor their symptoms, because there can be still recurrence rates that are, significant.
I think it really sort of shows, doesn't it, that in all the conversations we have around endometriosis, there's such little good quality research out there. We can't point to a randomized control trial and say, yes, this is the ideal treatment, or this is the best way to do something. And I think that the lack of funding and the lack of investment is huge in women's health, but in endometriosis, we really are sort of basement level. And I think that brings me around to the thinking of accessing care and barriers to accessing care. And, we know there's quite a long delay in a lot of cases for diagnosis, and we know that not every surgeon has the skill to remove endometriosis, use an excision, or even to remove it from all of the areas that it can be involved. And we're not just thinking about pelvic here, we're thinking about extra pelvic as well. Can you talk us through maybe some of the barriers that you see where patients are finding it difficult to get care?
Yeah, I have a long list, but I do think that access to qualified surgeons, or those that have experience, not just the excision component, but really detection, because I do think that we have, the benefit of laparoscopy, and yet, it does rely, you do have to rely upon being very systematic and thorough in your examination of the pelvis, because, I think we've, all encountered cases, or personally, have cases of, that one initial index laparoscopy not showing anything, and then later, in another surgeon's hands, potentially actually seeing disease, and probably disease that's not new. So I think, yes, sometimes, patients are forced to, or have limitations in terms of who can do their surgery. I think, if they are at the point where they are not responding to medications, or, other imaging has not really confirmed a diagnosis, that, unfortunately, sometimes I think it does take, an initial surgery, even if it's in the hands of someone who may not have the same skill set, but at least to, potentially patients can be proactive in asking for photos, or, having a discussion with their surgeon in terms of, being specific about areas to look at, and making sure that that's included in their operative assessment, even if they're not comfortable treating those areas.
And often that is the case where, a patient may be presented, to a routine gynecologist, and, ablation is the only thing that they're able to do within that short space of time, as well as within that skill set. And I think, certainly from patient feedback, often they see that that is their only next step. And after they have the confirmation of diagnosis, then they may be able to take that information and try and seek out somebody who has more specialist training, and maybe more better skill set in terms of excision and that as well. So it's quite a tricky one. And I think I'm certainly seeing a lot of younger patients presenting with symptoms. I think that's a wee bit more on the awareness side as well too. And maybe some of the parents are now starting to see some of their children coming up with endometriosis symptoms as well. So do we consider surgery in very young patients, or what would be the treatment plan for somebody who'd be very young?
Yes, so I think sometimes, in younger patients, as a whole, I think there's potentially more hesitation, I'll say, to offer surgery. Maybe it's, our bias in terms of age. Not that surgery isn't beneficial in that age group. I think that there is just, potentially fear in, having patients at such an early age start that process or that journey. I think that in patients who have specific features, like I said, very painful menstruation, school absences, other types of pain too, like we talked about, those are all, fairly good diagnostic criteria, I think, to make a clinical diagnosis. And so surgery, may not be required for a diagnosis per se, but potentially could be helpful in terms of reducing pain if they're not responding to the initial therapies that are often first recommended. I think that adolescents also, though, even if they have surgery and do well, I think it's also important to kind of focus on potential need for continued medication, over time. That's not always the case, but often, that is part of our conversation, in pairing it with surgery.
Yeah. And could it be the case, say, in a very young teen, that maybe all endometriosis is not, fully visible or fully even developed at that stage, during that first surgery? Could it be then that maybe they would need more frequent subsequent surgeries?
Yeah, I think that's an area definitely, to be investigated, because we do know that there's probably like evolution of the endometriosis lesions, and there are younger appearances, especially in those in their teenage years, where it's not classic. And so I think, in terms of if you think about if their first surgery is in their adolescent years, and you think about what we already talked about, recurrence rates and need for a subsequent surgery, they're inherently going to be at higher risk, I think, of needing more surgeries in their lifetime.
Yeah. So it's the offset of, you know, early diagnosis and early treatment, isn't it, versus the lifetime with this disease. And I think that's one thing we do need to remember as well, is it, you know, this is a chronic condition, and, you know, surgery goes a huge way towards managing a lot of those symptoms as well too, and helping restore anatomy to normal. You know, I'm so conscious of the time here, because we could be chatting all night. I'm going to have a wee look at some of the questions here to see if there's anything that we haven't covered. Let me have a wee look. And in terms of incidents around the extrapelvic endometriosis, do you see a lot of that in your own practice, or would you refer out for something like that?
Yeah, so I think specifically, you know, although MRI is helpful in detecting extrapelvic endometriosis, specifically deeper disease of the bowel or bladder, there are, you know, situations in which we can't detect, you know, for example, diaphragmatic or thoracic endometriosis reliably before surgery. So often in those extrapelvic regions, those are cases where I think that often, unless you have a good clinical suspicion beforehand where they have, you know, pulmonary symptoms, those are situations where I do collaborate with our thoracic and cardiothoracic surgeons, potentially for a separate surgical date to treat that specific disease, especially if we don't have a high index of suspicion going in.
Yeah, that's back
yeah.
to the good planning again, isn't it? It really is.
Mm-hmm.
And just one sort of other question here, like about, you know, different opinions around, you know, postmenopausal. And we have read some cases in literature where patients have been diagnosed maybe when they're menopausal, and some people continue to have symptoms as well. Can you sort of take us through very briefly about that, and what your sort of caseload would look like? Would you see a lot of menopausal patients with symptoms?
You know, I don't ever assume that it's not endometriosis, I'll say, even if a patient is in menopause. I think that the percentage of patients who present in my practice in the menopausal age range with endometriosis being kind of the primary driver of their pain is not very common. Although I think, you know, we do very often see patients who, you know, typically who have had prior, I'll say, like surgical confirmation of disease. You know, on occasion, you know, some patients will have new onset pelvic pain without having had, you know, the classic kind of features in their reproductive years. And I will say usually there may be other elements contributing to their pain in that situation, where it's less likely for it to be kind of, you know, a new diagnosis of endometriosis, let's say. It's usually patients who have had endometriosis and then continue to have symptoms even through menopause.
Yeah, makes sense. Oh, it's the gift that keeps on giving, isn't it? It really is, you know. One sort of question here around the risks of not having your endometriosis removed. So the risk of not going through surgery, is there anything for leaving it there?
Yeah, that's a great question. I will say that, you know, some patients are content with not having surgery and prefer not to have surgery. As a surgeon, I never like to recommend surgery unless I really think it's valuable. The danger of having untreated endometriosis, I'll say, is obviously if the endometriosis is causing pain, I think pain obviously can affect you in a health, you know, can negatively affect your health on many different levels. But in terms of physical risk, you know, endometriosis is a chronic and progressive disease in most. And so very infrequently, I'll say, can it lead to cases where there's obstruction of bowel. There can also be obstruction of the urinary tract, which some patients may not have classic pain, but can have features of, you know, diminished renal function or evidence of abnormal sort of kidney function on imaging. So those are cases where it can actually pose a health risk of leaving it untreated.
Mm-hmm. And I suppose in terms of, you know, maybe like colorectal endometriosis or certainly we know about the bowel symptoms. Would there be any particular warning signs or sort of anything that the patient should be very much aware of in terms of, a potential bowel obstruction or, endometriosis progressing to that point?
So, some of the symptoms overlap with other common GI symptoms or conditions, unfortunately. So, I think the more concerning symptoms related to bowel function would be observing blood in the stool, or having recurrent bouts of, nausea and vomiting. Those would be more concerning for an obstruction. I think often we see a lot of patients with endometriosis with, generalized symptoms, constipation and bloating and that sort of thing. And that can also, be seen in other coexisting conditions too. So so those are usually less concerning symptoms. But, if there's ever a symptom that's of concern, that's always something that's important to bring to your doctor's attention.
Yeah, absolutely. And it's any change, I think, as well, isn't it, for the patient that they feel is different. And I suppose just again, as we're sort of coming to the end of this, and, as somebody who's been through multiple surgeries and has had their endometriosis excised, we know it brings great benefits, but aside from removing the lesions, can it help with the systemic effects? So say like the fatigue, maybe the nausea, the joint pains, the migraines, all the other lovely bits that go along with it. Can we expect to see, I suppose, a long-term benefit that way?
So that is a really important question, I think, because all of those symptoms are really do affect quality of life beyond pain. Those are all symptoms that, unfortunately, I don't think that we have studies that actually truly evaluate those specific symptoms and outcomes. We do have different types of questionnaires and, other kind of like health-related questionnaires that we can kind of calculate scores and ask about like pre and post surgery. But I think no one's done like a really deep dive in those specific things as it relates to endometriosis. But I think, in the patients that I've cared for, I think, you will definitely come across patients who have additional benefits even beyond reduction in pain, all of those that you've described.
Mm-hmm. And I suppose final question for you before I let you off the hook altogether. If you have done a fantastic excision surgery on a patient and you're going to, send them off with a care package, and what would be your main referrals and recommendations for improving, I suppose, our recovery and making sure that we look after ourselves? And is there anything that we can do as patients to reduce our risk of recurrence, or is it just in the hands of our genetics?
There are not specific lifestyle modifications or behaviors necessarily that we would, recommend for the immediate recovery phase or even beyond that. I think we all really strive to emphasize overall good health, in terms of, paying attention to your diet and activity levels, because we all know that, overall is very influential in recovery. Other things just for patients who have, undergone surgery, I think to be attentive in how they feel in terms of changes, like you mentioned. Often if we do see improvement in their pain and function, that if they, are monitoring or kind of, feeling that, their pain is slowly returning, or even if those around them have noticed that they seem to, not be doing as well in terms of their day-to-day activities or, ability to work or to interact. I think those are all things, soft kind of clues to focus on too. But probably to, align with your, whether it's your family doctor, having someone in your healthcare team who can really help coordinate continued care with your surgeon or your endometriosis specialist, because there may be times that might be necessary to kind of keep returning for monitoring or surveillance.
Perfect. Professor Young, this has been fantastic, and we certainly could chat for hours on this. My favorite topic. I hope everybody has learned something this evening. I've absolutely learned loads, and there is loads of questions we didn't get to, so we might sort of see what we can do with the guys in the telehealth crew to see what we can do around getting maybe some more answers there. Again, want to thank the guys at telehealth for inviting us this evening. It's been a fantastic opportunity to speak about endometriosis, something that we should all talk about every day so that everybody knows about it and we can all get diagnosed early and get good surgeries. And the telehealth app as well is a new social media app where we have clinicians who are verified, so you know that you're not getting any misinformation or dodgy medical advice on the internet. Thank you everybody for joining us, and Linda, thank you again. It's been great chatting to you, and I look forward to sort of, you know, catching up with you again in the future.
Likewise.
Okay.